to the Hill about the healthcare workforce and pathways for retention, pathways for medical students, pathways for residents. And so this is a very important topic that we're really excited about. So please welcome up our panel for this healthcare workforce discussion. Let's give them a round of applause.
Good afternoon, everyone. Thank you for bearing with us through this afternoon. We're going to give it about 2 minutes just for individuals to kind of resettle and regroup who are coming in and out between the two sessions, and then we will get started in 2 minutes.
Oh, that's wrong.
We're going to get started. Thank you all again for joining us and for bearing with us as we work our way through our last session. You know, the last is the best. We hope that this is a productive conversation. We have an excellent panel with us to really have a discussion that is near and dear to my heart and many of our hearts. I want to introduce myself first. My name is Chidimma. I'm the current chair and trustee of the postgraduate section for the National Medical Association. I'm a pediatric emergency medicine fellow here in Washington, D.C., and a former member of the board of directors for the Student National Medical Association. So this topic of addressing our pipeline, really thinking about sustainability for our diverse workforce, particularly as we think about our medical students, our residents, our fellows. Obviously, as a person who is still very much in that pipeline is important for me to be a part of. So I'm just so honored to be able to sit down with our panelists, who I will introduce shortly, to discuss this topic. And so without further ado, I will start with our first panelist, Dr. Billie Downing. Dr. Downing is a board-certified family medicine physician who has practiced medicine here in Washington, D.C. and Maryland for the past 14 years. Dr. Downing attended the University of Maryland, College Park on a full 4-year academic scholarship, the Benjamin Banneker Scholarship, which was designed for African-American scholars and future leaders. Dr. Downing went on to earn her medical degree from the Howard University College of Medicine in Washington, D.C. in 2006. She completed her family medicine residency training at Georgetown University Providence Hospital in 2010. Upon completing her residency training, she returned to her roots at Howard, and she created and fostered the Family Medicine Obstetric Training Program as an associate professor. From 2013 to 2022, Dr. Downing worked in the private sector, working in urgent care and primary care at Patient First Urgent Care Centers as a staff physician. In 2023, Dr. Downing went on to assume the role of medical director at the MedStar Health Primary Care in the New York location. Dr. Billie Downing currently serves as the Howard University Hospital's Family Medicine Residency Program Director and as an assistant professor in the Howard University College of Medicine. Over the span of her career, in addition to delivering exceptional patient care, she has taught numerous medical students and residents, mentored younger physicians and physician assistants, done culturally impactful research, and worked as a medical director for 2 medical offices, grossing an annual revenue of $6.8 million. While Dr. Downing is humbled and honored to care for newborns to the elderly, she is truly blessed to be married to her best friend for the past 25 years, and to be the mother to 3 amazing children, ages 23, 19, and 12. I welcome Dr. Downing as one of our first. Our second panelist is Ms. Bridgette Hudson, who is the Executive Director for the Student National Medical Association. Ms. Hudson is a dynamic nonprofit leader with more than 20 years of experience in driving impact and mission-driven organizations. She joined the SNMA in May 2022 at the height of the COVID pandemic, stepping into the role of Executive Director after the organization had been without leadership for over a year. Since then, she has played a pivotal role in strengthening the SNMA's programming, expanding its reach, and ensuring the continued success of its mission to support students underrepresented in medicine and increase diversity in the healthcare field. Before joining the SNMA, Ms. Hudson held key leadership roles at Society for Science for the Association of the American Medical Colleges, the AMC, the AAMC rather, and the American Institute of Architects, where she led strategic initiatives in alumni engagement, educational pipeline programs, and organizational development. As Director of Alumni Relations, she developed and executed the organization's first comprehensive alumni engagement plan, connecting a network of over 70,000 alumni, including 13 Nobel Prize winners and 8 National Medal awardees. At the AAMC, she worked extensively on pipeline and pre-medical programs, supporting initiatives designed to increase access to medical education. She was instrumental in creating the Rubens J. Paines MD Opportunity Fund, a scholarship designed to reduce financial barriers for students pursuing careers in health professions. Ms. Hudson holds an MBA from the Johns Hopkins University Carey Business School and a bachelor's degree from the University of Connecticut. She currently resides in Washington, D.C. Her passion for equity in education, strategic leadership, and commitment to advancing diversity in medicine continues to drive her work at the SNMA and beyond. We welcome Ms. Hudson to our panel. And finally, we have Dr. Dotun Ogunyemi, who is currently the Designated Institutional Officer with the DIO for the Graduate Medical Education and Chair of Obstetrics and Gynecology at Charles Drew University. He completed a residency in Obstetrics and Gynecology at King Drew Medical Center in Los Angeles and a maternal fetal medicine fellowship at David Geffen School of Medicine, UCLA. He was previously the DIO for GME and Associate Chief Medical Officer at Arrowhead Regional Medical Center in Colton, California. Prior, he was a Senior Associate Dean of Faculty Affairs and Chief Equity, Diversity, and Inclusion Officer at the California University of Science and Medicine. At Cedars-Sinai Medical Center, Los Angeles, California, he was the Residency Program Director, Clerkship Director, and Vice Chair of Education in OB-GYN Department. At the David Geffen School of Medicine at UCLA, he served as Clerkship Director, was on the Medical Education Curriculum Committee, and as Vice Chair of the Student Thesis Program. In Michigan, he was the Vice Chair of the Patient Safety ACGME MFM Fellowship Program Director, and the Director of Research for Students and Residents in the OB-GYN Department at UMass. His academic interests are in medical education, patient safety, wellness, and DEI. He serves on numerous editorial boards and is an active leader in ACOG, ACGME, and the OB-GYN section of the National Medical Association. He is also the chair of the Educational Council for the NMA. He has over 100 peer-reviewed publications. In what little free time he has left, who knows, Dr. Ogunyemi also founded the DOF Foundation, which is a 501c3 nonprofit foundation which provides mentoring, academic enrichment, community focus, and support for selected students with the goal of successfully matriculating into college, medical school, and other healthcare professions. We welcome Dr. Ogunyemi. Okay, I'm going to sit down so we can have a conversation like some friends, okay? So. Okay, so I first just wanted to outline some of our key objectives for today so you have an idea of what we're going to be talking about and what our panelists will share with us. And then there will be some time towards the end of our discussion for us as a group to really brainstorm some strategies that we can all walk away with to do and some charges for the National Medical Association to take on as we continue to address this important issue. So our session objectives are going to be to first discuss the current landscape of diversity in the healthcare workforce. We will also identify key challenges and limitations for K-12 and pre-medical students, medical students, trainees, including both residents and fellows, and practicing physicians. And then, as I mentioned, towards the end, we will brainstorm actionable objectives for the NMA and other collaborating individuals and organizations to address these challenges. Okay, so my first question is for Dr. Ogunyemi. And I would appreciate if you could just describe how the demographic of the physician workforce has changed over the past 20 to 30 years.
All right. Thank you for that question. I'm sure a lot of us are aware of this information. And I'll try to start with the medical school because that's the easiest and most complete data that we have because the AAMC collects that data yearly. So the last data that came out was for the 2024-2025 matriculation into medical school. And during that year, the current first-year medical students, about 50,000 students matriculated into medical school. And it's very interesting to look at the data from various perspectives. If you look at the data from race of acceptance and matriculation, so if you're Asian and you applied to medical school last year, you had a 50% chance of being accepted, and then you had a 48% chance of actually matriculating to medical school because not all students who are accepted end up in medical school. So if you're Asian, it was about 50 to 48. If you're white, it was about 50 to 40, 48, 49. If you're black, it was about 45 to 34. And if you're Hispanic, it was also about 40 something to 34. Basically, summary of the data was if you're Asian or white, you had a high chance of being accepted and a high chance of getting to medical school. Then when you look at the data from GPA as well as the MCAT scores, which are the other things that medical schools look at as well. So if you're white or Asian, your GPA getting to medical school average was about 3.7, 3.8, and your MCAT score was about 512, 516 if you're Asian or white. However, if you're black or Hispanic, your GPA was about 3.3, and your MCAT score was more about 505, 503. Again, showing that what we know is that the Asian and white kids are smarter than us because they are better schools to go to, they have more resources, they are more networking, they have more homework that they get help with. So they tend to have better GPAs and better MCATs, and therefore they have a chance to get in medical school. Whereas when you look at the black and brown students, they are actually getting very specific medical schools. not all medical schools take black and brown kids, and the ones that take them really work with those students knowing that they have these issues with their backgrounds being able to get into medical school. So from that perspective, again, we tend to do lower than that. Now, if you now look at the overall representation, that's looking at what percentage and comparing New York with the percentage in the nation. So, for example, if you look at it from the white population, they're about 55% of the population, but the percentage of the medical students that matriculate was about 37%. If you look at it, was Hispanic is about 19% of the population, only 6% of medical students are Hispanic. If you look at it from the African American, the population is about 13 point something percent, only 9% are black. And if you look at it from Asians are only 6%, or 1 out of 4 medical students are Asian. So that is the underrepresentation focuses on basically black and brown, and then of course the Asians actually have a higher percentage. Now, so that's with medical students. Now, if you want to look at residents, it's very difficult to get data on residents, but I'll just give a very practical example to just highlight the point. I trained in Kingdom Medical Center. Kingdom Medical Center was a hospital that was created because there was a Watts riot. Kingdom Medical Center was in the South Central area. That area didn't have a hospital unit, and then there was a riot because a black woman was going downtown to the hospital, and then she was stopped by the police, and there's a riot, and they shot her. And then there was this big Watts riot, and as the result of the Watts riot, they created the Kingdom Medical Center, and they also created the Charles University, which I am today. And what happened was Kingdom Medical Center was just as same resources and expertise as Harvard UCLA, which is the white hospital down the road from us, as well as one downtown. And then what happened was, again, this is a true story, there was the Iraqi war occurred, the county lost funding, and they needed to close a hospital. They had 4. They tried to close a hospital called Rancho. They went to Rancho took them to court, and court said, you can't close this hospital. Then they went to Harvard UCLA, which is the white hospital, supported by UCLA, and UCLA raised $200,000 that day and stopped the county. Then the county came to Kingdom Medical Center and said, this is the most important hospital, and then they transferred 30% of nurses out. And then when everything happened, they ensured that no resources were given and no correction was done. So eventually they allowed the hospital to implode and they closed it down. Now what has that done? When the hospital was there, we had 18 residency training programs that were compatible with it. We had dermatology, we had anesthesia, we had orthopedics, we had neurosurgery. That hospital today trained 1 out of 4 black physicians in Los Angeles area. That hospital closed in 2005, and since then, there's been nothing. So again, what happens is that we have these few institutions that train us, and then because of the issues of racism and discrimination and lack of resources, those places are tagging and they close down, and that results in the fact that the few places that can train us are not there anymore. Now, when you look at it from the point of view, so those are residents again. Now, when you look at it from the point of view of faculty, again, if you look at specialties, again, there are specialties that have more representation. So again, obviously, our family medicine and internal medicine, there's more representation there. But when you get to places like orthopedics, then you get to ENT and neurosurgery, plastic surgery, that representation suddenly disappears. And then when you look at it from the point of view of leadership skills, okay? We know that now about 50 to 60% of physicians are female, and a lot of them are black. But again, when you look at the professors and the chairs of department, then there's also underrepresentation there. And then again, very quickly looking at black men in medicine. So again, studies show that since 1978, the rate of black men in medicine has been stagnant and has been decreasing. Now there's a slight increase now, but it's still decreasing. And I want to leave you one fact. There was the Supreme Court ruling that affirmative action is no more. Now when you look at the data, so again, WMC collects data yearly, and so the last they showed that this year, even though there was a 2.8% increase in number of black and brown students who were applying to medical school, there was an 11.6% decrease in the number of Black students matriculating medical school, and was 10.8% for Hispanics. And then when you look at, and they say since 2023, that decrease has been every year. So for the first time in the last 3 years, we've shown a decrease in the number of students. So again, these are things that happen nationally that's actually affecting it, and you can see the results of that. Thank you.
Thank you for setting that landscape. I will also open it to our other panelists. Whether you have some additional thoughts or even just based on what Dr. Ogunyemi said, what do you think is the most damaging of the deficits that exist?
I would say the most damaging of the deficits that exist is the patient-doctor interaction. Just the data from the standpoint of how patients respond to physicians who look like them, how their outcomes are from the standpoint of disease burden, which the last panel talked about medications. There was a physician over here who spoke about food as medicine, being able to interact with the patient and meet the patient where they are. I would say that is the most damaging result of the lack, and therefore, and also the decrease as far as medical students that are represented.
I think I just wanted to go back to a little bit about the data, and especially around GPAs and MCAT scores. I would say that the difference between the GPAs that were presented and Black and Brown students were within margins of error, that I don't think that if you take into account the fact that our students are coming from K-12 systems that don't adequately prepare them to take standardized exams, some challenges around access to MCAT prep classes, or even just early access to the sciences. As someone that worked with pipeline programs, we get students that find out, or they come to medicine or healthcare professions much later than a lot of those other counterparts, because they're either exposed to folks in their communities or whatever that may be. And that presents a challenge if you're trying to get the information that you need to know what it means to be a successful medical student candidate, and then also tap into resources that may not be available from your institutions, that may not be available from your family, because of course we know that awareness, education, and access does make a difference in terms of what we're able to do in our communities. So I know our students are, I would say this as someone working with medical students, and probably there's no, I would say, I'm going to use this word, it's not good, dumb medical student. I don't care what their background is. You cannot be, you are very intelligent. People that are in those schools are very smart, they're very curious, they're very capable. And so what, the narrative or what's being presented is that somehow they're not worthy, which is the discussions that's been happening outside around DEI in general, is that somehow leveling the playing field or having equitable solutions to address institutional problems and deficits somehow makes that person less. Actually, they tend to be scrutinized and tend to be more qualified in that regard. So I do think that, which is happening again, if you hear the changes that are going to happen at the Department of Education, that I think is going to even exacerbate more the preparation that we know a lot of our members of our community and students from urban and rural, because I think there's a myth that it's only urban or folks that looks like us that will be impacted by those changes. That's going to, maybe in 4, 5, 6 years or even longer, you're going to see some of those decisions really play out in all careers actually, and medicine and all of them will be the most impacted by that as well.
Ms. Hudson, I think you did an excellent job of really also framing some of the challenges specifically for medical students of color. And as the executive director for the SNMA, can you talk a little bit specifically about what that organization does and some of the initiatives that exist that are helping to address some of these challenges?
Sure. So, SNMA is a space of belonging. If you think about it, we have over almost 7,000 medical student members. And the average medical student class, especially with Black and Brown, is probably about 3 to 5. I mean, except for Meharry and Howard and Chester, and Morehouse. Those are, really large classes. But most of our medical students are in spaces where there are a class of 200 and there's 10 of them, right? And so, you may have one per class. And so SNMA has always been this space where we've actually built our own tables for a lot of things. So we have our conference, we bring in physicians, we bring in mentorship programs that are focused on making sure that our members know that they're supported, that there's a space of belonging for them, and that they are valued and they're contributing to the profession, and then also wanting to do good for their communities. But not just doing good for the communities in the sense that there's a lot of discussion about being family physician, but we need all physicians from, to support our communities. And I'm really, really excited to come here and say that on our board, which is, our board is mostly medical students, we had 14 fourth-year graduates, we have 3 surgeons, we have 1 anesthesiologist, a diagnostic radiologist, we have quite a few, just all across the professions and the specialties, and that's really important for us to also talk about because we want diversity, we want access, we want increased numbers in all of those specialties because we're all impacted by them regardless of our race. And so SMA does that with we have specialty interest groups, we have quite a few pipeline-focused programs, intervening and working with elementary and junior high school students, all the way, of course, through our medical students that we do. And a lot of those programs are listed on our website, and I'm happy to talk in depth about that. But I think the most important thing is that SNMA, besides being a place of belonging, does really provide that support, that network, that opportunity, engaging with physicians. Many of you have worked with our students at the regional level, at the chapter level, and then also when you come to our conference and support the recruitment efforts to make sure that your programs are diverse.
So I think it's so important that we can start, honestly, we can start even before our students get to medical school, and having some of these pipeline programs allows there to be representation for our K-12 population, which we'll also talk about a little bit as well. But the reality is that you cannot feed what you can't see, and so being able to use those who are already in those positions, whether they're medical students who are reaching back to our middle school and high school students to show them the opportunity that exists, or residents and fellows who are reaching back to medical students to show them opportunities that exist, or physicians like all of you in the room who are the coup de grace of where the light ends at the end of this tunnel of training and schooling. It is very important that we all continue to play that role and be present there. As we think a little bit specifically about our trainees, our residents and fellows, the ACGME consistently reports that termination from residency is exceedingly rare. However, many of us have seen firsthand or experienced a reality that really counters that assertion. Dr. Ogunyemi, specifically, can you discuss some of the current trends that you've seen in training dismissals and some other disruptions that are not necessarily captured in the data, such as remediations, performance improvement plans, withdrawals that really disrupt and affect residents' opportunities to get to and through residency training?
Well, thank you for the question. So the data says that the latest is that about 5% of residents are terminated. But then when you look at the underrepresented populations, actually 20%. So again, theoretically, if you're black or brown, you have 4 times a higher chance of being terminated in your training. So when you look at that very carefully, again, some of the reasons that we're giving is part of that. If you do not have the same chances starting with the others, then you have much more to catch up with, and your program may not see that. So again, one of the factors is we're coming in with, our students are coming with less mentoring, they're coming in with less networking, they're coming in with less understanding of the process of where they are, and they're also coming in with a lot more learning and social deficiencies. So one of the things I talk about is that when you're looking at training, and you're talking about competence, you have to look at what we call the distractions. and the distractions sometimes are much more important than the skills that you require. Because if you don't have a place to sleep, and you don't have a roof over your head, and your relationships are all chaotic, you can't really focus on learning. So what we noticed again is that when I look at our population of learners, I call them, I'm using the term, I've stopped saying struggling learners now, I say learners in need. That's my new term. It's now learners in need, no more struggling learners. That these learners are in need, that's what they have needs. And when you look at our population of these learners who are struggling, at least 1 out of 3 of them have a mental problem. They have some wellness issues, they have some depression issues, they have some burnout issues. And if you don't deal with that, nothing else is going to work. If you're not mentally alert, competent, focused, you cannot do your work and you cannot learn. And so unfortunately though, the medical education program has been made to believe that they're not allowed to talk about that because they can't be the doctors to their lives, which is true. So instead of looking for a process to deal with that, they just ignore that and focus on the competency. So if I'm mentally ill and you tell me to go and see patients and I start acting out, it's part of my mental illness and you're not taking care of that. So again, one of the major issues in this area is that we're not focused on the wellness and mental illness that the students have. The other one is also the social factors. Our learners in their 20s and 30s, when they're living life and making mistakes, they have relationships that don't work out. They have financial issues, there are parents who are sick and all of that. And that's a major one. I've seen a learner who's sleeping in their car, whose apartment got burned down, whose girlfriend, whose wife was being targeted by someone. All these things, if you don't deal with it, they can't do their job. So that's another area that you have to look at. So now, taking those out, now, it's very important to realize what residency training is about. Residency training is a competency-based education. And what competency-based education means is that you come in knowing enough, you're completely incompetent when you come in there. So you're going to make mistakes because you don't know. And nobody has shown you. So making mistakes is part of residency training. And so people learn by 2 things, by constructive feedback and deliberate practice. So if you don't give me the constructive feedback in a way that I can understand and accept, I don't trust you, you don't talk to me in the language, you've already done some things to me that I feel that you're really against me, then I'm not going to hear that feedback, and then I don't have that to learn. So again, is this issue about do we have faculty who know how to provide what I call compassionate, constructive feedback and use that and observe again. One of the things we do again is because we all sorts of time. I was just talking to some learners, I was talking about I need somebody to come and observe me. You have 15 minutes to see a patient, have these ongoing issues that have residents in an FQHC, and the FQHC is complaining that the residents 4 residents make 1 faculty because the residents cannot see patients as fast as the faculty. And so there's all these financial issues, and the point is, if the faculty does not have enough time to go into the room and observe the resident, that's how you give feedback. That's how you know what they're doing. That doesn't happen. So there are many places where structure is broken. I'm going to stop here. If you want me to,
Yeah, I knew that I opened a Pandora's box. There are so many different caveats, and there are the social pieces, there are the institutional pieces as far as just how the structure of residency is designed, and in particular this piece that you mentioned about how you are actually supposed to come into residency incompetent.
Yes.
And the point of residency is to make you competent,
Yeah.
I feel is not always applied equally to our trainees, that often from very early out the gate, medical students who are transitioning into residency are being penalized or punished or placed on performance improvement plans because they are expected to know things that there is no way they could have known prior to reaching residency. For example, a resident in obstetrics and gynecology being a first-year resident who is now in their 1st or 2nd month of residency getting constructive feedback or getting penalized and attacked about their surgical skills. But that's the whole point of residency, is that you have 4 years to be a surgeon. And there isn't necessarily a whole lot of time you've had in medical school to do the cutting.
Let me even add to that. Part of competency-based education also means that people progress on different trajectories because they learn differently. And so the whole concept of competency-based education is that you should be able to, some of your learners are going to be fast, and maybe a 4-year resident they can finish in 3 years, even though we don't let them do that. And some of them are going to take 6 years or 5 years. So the point is that when you work with a learner, you're supposed to let them progress at their space and support them to do that. That's something that we're not doing. And really supporting what Dr. Acholonu just said is the fact that there's this issue about stereotype, right, as well. There's this issue about dominant culture. There's also this issue about different expectations. There's also this issue about harsher penalties. And the point is that when you look at faculty, and this is what really is scary, is that we don't see ourselves when we're doing something, but other people see us. And when that's pointed out to us, it actually makes it worse, because now you feel I'm such a good person and you dare tell me that I'm discriminating against someone. And the point is that our faculty, they treat space learners differently, and the learners see that. And once the learner is treated differently, they say, okay, the way they make an harsh statement towards me, they smile towards me, that person starts withdrawing. And that creates this whole circle of emotional turmoil that creates results actually in a self-fulfilling prophecy. Because said the person is not good, you have not helped them. Again, just like you said, they come in as unconsciously incompetent. That's the first step. So when you look at the stages of learning, the first level is that you're unconsciously incompetent. You don't know what you don't know. And then all of a sudden they give you an answer and say, oh, I can't do this. And then you become consciously incompetent. And that's a very difficult place for people, because you see people who are experts and you don't even know how to hold the needle, you don't know how to take the history and say, and so there's a lot of anxiety, a lot of depression, a lot of fear about in this phase. And if you don't support those learners with emotional support during that period, you actually can't help them to get out of that phase as well.
Great. I'm going to pause you. I'm going to put you back in Pandora's box and close it a little bit. I do appreciate that you bringing up this piece of the conscious incompetency, and many of us know that as imposter syndrome. I think is another way that we can think about that, and that we are now very aware of what we don't have or what we lack. I do want to give our other panelists an opportunity to share if they have any thoughts specifically on this. The component of training, targeting, and the experiences of residents and fellows in particular.
So I actually was kind of surprised at some of the data that you presented from the standpoint of the GPA. As far as African American students and students of color, I was surprised about that. I don't know if anyone else was surprised about that in the room. The other thing that I wanted to say, as far as bringing in residents and fellows into your program, I always promote it has to be a good fit, right? So if it's not a good fit, then we can't date, we can't get married. That's the way that I right. That's the way that I look at it. So from the standpoint of how many residents are in that training program, what does the faculty, what are their beliefs? What is their training? What is the faculty's training to teach residents? Is this something that they are passionate about? Is this something that they're committed to? Or is this just a job for that faculty member? The other thing that I like to bring up from the standpoint of residents having to deal with so many different issues, some being socioeconomic issues. Even though our residency training programs give our residents a certain amount of money every month to eat in the hospital and to buy their food, I found recently that we had a resident who was, his food would run out before the end of the month. And so those are real issues that we may not have had to deal with in the past. Even from the standpoint of housing, flooding of housing, parents passing away, siblings passing away. And so making sure that residency, at the end of the day, we have to positively, absolutely, regardless of the color of our skin, by the time that you finish residency, you have to be competent. So it's my charge as a faculty to make sure that resident is someone that I would be fine with my daughter seeing, or I would be fine with my mother seeing. But also knowing that everyone progresses, just like you said, at different rates. And if that means that your residency is going to be 3.5 years, then that's what it means for you. Also making sure that residents know that it's not a penalty if you have to take a leave of absence. There's no perfect completion of residency. At the end of the day, we want to make sure that that resident is competent and able to do the job that we are teaching them to do.
I did want to just add just a few nuggets that talks about where do residents go to for support in a space where there's not really very clear where that can happen for them. And I'm talking about from the position that I've had students email me, residents email me, because when they were in medical school, they had SNMA, they had these other resources. But if you're in trouble or you're feeling that you may need a safe space to connect with someone to talk about the challenges that you're having, that you may not have at your residency program, there's really not, I would say, one space to do that. And I think that's something that when we're in our solutions phase, we can be talking about what's that bridge, right, between maybe SNMA and NMA, and not that they're not in NMA, but there's that 5-year period where they leave that they don't necessarily have access, or maybe we could do a better job of providing where they can connect in a safe environment to talk about the challenges, to help them work through, as you said, like this new shift. Again, residency is different than med school, which is different than college. So there's all these transition periods that I would say are very traumatic. And trauma doesn't always have to be bad, but that they do need support, and where we can provide more access to information, mentors, resources to help folks navigate that, because we don't want to have all these donut holes, like pockets of where we do a great job of getting people to apply to medical school, get them in medical school, but you don't necessarily graduate them. And so you keep having this funnel get smaller and smaller, and that doesn't advance what we're trying to do, which is to increase the number of diverse, competent physicians.
I will say that that space, that transition space of belonging, is the postgraduate section for the National Medical Association, which is the section for our residents, fellows, and early career physicians. And the goal really is to be that bridge, recognizing that the experience is very unique when you're transitioning from medical school to residency and residency to fellowship. And it's those who are either currently in it or who were very recently in it who understand it in a different way and can kind of help to navigate. And it's sort of a soft launch of navigating what is much larger than the SNMA when you're trying to understand how to then get involved with the NMA. It is something that we are working on to improve as an organization, and we'll save some of that conversation for our solutions part of the discussion, but do want to just frame it out there that as we're all thinking about ways that we can support trainees that we are with, the postgraduate section is the space for it, and we welcome them all with open arms. I gotta put in a plug, for my section. Moving on just to some other pieces, as I want to make sure we do have enough time to hear from our audience and to come up again with some actionable items. I did want to, Dr. Downing, you had actually mentioned earlier about the deficit and the danger being the patient and provider relationship and not having providers who look like you. And there is growing data that demonstrates overall better patient outcomes for communities of color when they receive care from physicians who look like them. So given your work as a family medicine physician and your work at Howard University, I would love for you to just speak on that a little bit more as far as what you've been able to see and some of the positive anecdotes that have come out of that.
The first thing that comes to mind has to do actually with nutrition. From the standpoint of, let's say for instance, if I see a patient and part of what I want to prescribe, if you will, is a change in nutrition, me being culturally competent enough to know that there's certain nutritionists that I'm going to refer you to, because I want to make sure that nutritionist is meeting that patient's needs, and it's not in a way that is unreasonable for that patient to achieve. So whether that patient lives in a food desert, or whether that patient doesn't have the money to get fresh vegetables and fresh fruits, or whether that patient doesn't know how to prepare the food in a way that is likable or palatable for that person. Me as an African American woman, I know that those things are important. Whereas there's other communities that may not understand that is important. But also talking with patients about exercise and how that plays into health, but also giving them ways that don't involve spending $350 a month for a gym membership. Doing things that are free, doing things that don't impact that osteoarthritis on the knee, as far as jogging, running, things like that. So those are just examples of what I would say that allow me to see the patient and look at them in that totality. For instance, yesterday I was seeing patients, and one patient got there an hour late. And even without seeing her, I've seen her, I would say 4 times, but even without seeing her, I told the nurse I would still see her. And once I saw her, I saw she had her daughter. She didn't realize that the appointment was an hour earlier. It took a little bit for me to say, I'll see her. But just understanding the barriers, transportation, childcare, working in person as opposed to working remotely. Those are all barriers that I could have, if I didn't see the patient for her, those are all things that I could have easily just dismissed. And that would have been impactful for her as far as her health and all the things that she had to do to come in to see me. But those are just some examples that come to mind.
Can you speak a little bit about some of the work that you do with your trainees specifically to address some of the challenges that you've spent some time highlighting and really preparing them and supporting them to get through their training program?
That's a good question. So from the beginning, as far as interviewing applicants, I always tend to ask, do you have support in this area? Because trainees are dealing with so much, and I always tell my residents, I've done a lot of things. I've been married, I've been pregnant 4 times, but residency is very hard. It's very taxing. So I want to make sure that the applicant has an excellent support system. In addition to that, with our residency, we actually have a behavioral health section in our residency program. So our residents are able to do something called Balance. And what Balance does is it allows them to debrief as a group, as a residency program, about challenging situations or interactions that they may have had in a space that is safe and is non-judgmental. We also provide advisors and advisees. We make sure that our advisors and advisees meet about every 3 months. We also go over in-training exams. Some of those will generate a performance improvement plan. Some of those will, those performance improvement plans may be required and some are not required. But it does give the resident a roadmap to studying and making sure that they are incorporating that as far as their educational process is concerned. Also, one of the things that we are doing, which was not something that I necessarily had access to when I was a resident, was we are incorporating wellness as part of this longitudinal 3-year experience. So wellness, it varies. So when we have didactics grand rounds, some days we may have it virtual. We have a regular cadence of virtual didactics. And so, of course, what that does is that the residents don't have to physically get there. They don't have to go through the snow. If you're in Washington, D.C., they may not have to get on the subway, but it gives them just a little time to breathe as far as this regular cadence of virtual didactics. The other thing is actually planning outings. It sounds so small, and it sounds like it's not impactful, but it actually is impactful. It helps to boost resident morale, and it also helps to bring them together as far as a cohesive unit is concerned. So those are just examples of what we do as a residency program to support residents.
Dr. Ogunyemi, in a timely fashion, please. I would love for you to also share some of the things that you do for training, and in particular, the work that you've been doing with the Educational Council of the NMA.
Okay. All right. So
You're on the clock, serious.
So let's get started. All right. I really want to comment on your issue about wellness, and I think that it's important, but it's difficult. And one of the difficulties with doing wellness is one, are the faculty also well? Are we focusing faculty, or we being hypocrites? We're telling the residents to do something and the faculty are upset and actually being passive aggressive about it. So one has to look at the faculty aspect of it. The second one is this super person thing that we do to each other. We pretend that we don't crack, and really it seems like it's a badge of honor. And the learners, the more that they are thinking, the more denial they go into with that. So when you're doing wellness events, it's important for you to make sure that's accepted and not really just some functionality. So I do think wellness is important, but I struggle with making sure the learners actually are engaged and integrated into it. So having said that, so from my perspective, just looking at, again, we know that of all learners, like I said before, in many places, only 5% of them struggle. In our HBCU-oriented programs, actually 20% of them struggle, and that's really a large number, and that's a big drain of faculty. And then in our institutions as well, we don't have excess faculty to start with, and so when you have faculty, you have to deal with all of this, actually also impacts the faculty. So what I think is important that we all need to do, first of all, starting at this level, is that I think the most important thing for a learner, because residency is still a rite of passage. We all went through it, we have to go through it as well. And it's not easy, it's tough. That's the truth of it. Is that residency isolates. They're coming from medical school, their first job, for God's sake. And they're not only working a job, they're also learning. So what tends to happen is that precious things that they're deficient in, that have not shown up when they're medical students, because all they were doing is studying, now shows up, because not only do they have to study, they also have to learn, and that creates a situation where interns really are very, very a group in high danger. So my point is, I think it's important, first of all, again, I'm looking at this from a primary perspective, is that we need to start working with the medical students in the fourth year to belong to a cohort, and to make sure that they already have a cohort with them that goes with them into internship. Because once they go into that internship, they are isolated. There's no way out of being isolated. So now in the program, what can you do in the program? So again, what can you do in the program? Again, you talked about advisors and all of that. So that's very important. But the point is that you can have advisors who are not trained. All of us believe this thing. Nobody here is a teacher because you didn't go to teaching school. You have to learn how to teach. And that's one thing that we're arrogant about, that we feel that we can just teach people because we're doctors. We can. There's a process to that. So again, I feel that if we're using this advisor thing very well, my concern is that a lot of the advisor process actually creates issues because it results in lots of implicit bias and issues that occurs with that. So the first thing is that we're going to use advisors and coaches. You need to send them for training on how to do that properly, and that's very important. The studies that show very clearly that if you start coaching your medical students or your residents or your interns from the first year, it actually improves their outcomes regarding wellness as well as less professionalism issues. Because that gives them a space to go and talk to someone who just asks them questions, who doesn't judge them, and allows them to actually come up with the results of their issues by them actually analyzing and reflecting and getting there. So coaching is very important, but it's important that they are trained, that people doing the coaching are trained on that. Now, the other thing that we're trying to, I think what we're also trying to do is that when a learner is not struggling, they need a neutral space. And the issue is that because if you're the program director and the faculty who's telling them that your milestone is 0.5 when it should be 2, that creates already an enmity in the mind of that person. And so you can't do this, you can't do the two things. You can't assess them and then coach them to correction. So one of the things we've done is actually take that out of the department and create 2 coaches and do that in a central place. So that's one thing that we feel is helping. The other thing is that, this is what I think is very important, is that many of us, we see a milestone, we say, I'm sorry.
He's wrapping up, guys. You see him.
Okay, all right, I'm going to do this one. So this is important. This is important in the sense when you have a learner that's struggling, just like when you see a patient, you need to make a diagnosis. And when you make the diagnosis, you need to provide the appropriate treatment. What we do with our learners is that we just tell them that they don't see patients at the time, they're disorganized, and we tell them to go fix it, but we don't help them fix it. So the point is that when you look at learners, the areas they struggle most are with clinical reasoning, with organization and efficiency, and test-taking ability. Those are the things that learners usually struggle with. And the point with all that is that you need to have somebody who's trained as a domain expert in that place. So again, what I'm going to tell you is that if you really want to help your struggling learners, there's training you can do in those areas, remediation training, and then those learners can be sent to that expert and then help them correct that. So I'm going to stop there.
Good job, because you have 90 seconds left.
Okay, so again, we're gonna take some questions from the audience very soon. The very last thing I wanted to just ask the panelists to reflect on is, so for those physicians who have scaled the odds to make it to medical school, they have overcome the countless hurdles to successfully make it through medical school and residency. Can we talk a little bit about the challenges that now exist that compromise practicing physicians' ability to remain in the physician workforce?
I think we've already talked about it, just from the standpoint of, I would say, when I look at the pandemic, I feel like there's positive things that came out of the pandemic in addition to negative things, if you will. And one of those things that I think was magnified was that work-life balance, right? So physicians, many of us were on the front line through the pandemic, but it also allowed us to turn the mirror around onto ourselves. And just like you were speaking of earlier, as far as the faculty not being well, or the physician not being well, that the pandemic allowed us to stop and do, I would say, a temperature check on ourselves. So work-life balance is something that I would say is something that is in the forefront now. Quality workforce, so support workers from the standpoint of nurses, medical assistants, front desk staff. Like, from my standpoint, when I come into an office, even before I get to the office, it's the website that I'm seeing first. And that is what represents that office. So if the website is not up to date, if it looks like the pictures are from 20 years ago, that creates the whole atmosphere of me even going into the office. And that's how I want my office to look. I want the website to be pristine. I want there to not be chips of paint falling off the walls. I don't want there to be cracks in the chairs. But I'm saying that from the standpoint of I hate to say human capital, and I don't even take that away, but that whole experience, whether it's the person who answers the phone, the front desk staff members, we need quality support staff. In addition to that, would be training, as far as continued medical education training, making sure that you're up to date, making sure that you are going with the tide as far as learning and continuing your medical education.
Okay. Did you have something else you want to add, Dr. Lee?
I can always add.
Why don't we open it up to our audience first, and I'm sure that someone will give you another opportunity to share. Do we have a microphone that we can pass around?
Thank you. I want to share some comments from pediatricians that actually might work with regards to trainees and keep the pipeline going. To the comment, Ms. Hudson, with regards to SNMA, their pediatric interest group has reached out to NMA. We have had Peds Week, at least for the past 4 years, where they actually have faculty who are pediatricians in a variety of specialties come to us, or we come to them virtually and open up the floor and talk about things. What's it like to match in a residency program? What's it like to do a fellowship? How do you manage finances? How do you manage getting bad news? What's the way of managing work-life balance? So the pediatricians in that regard have been very, very active, or the students going into pediatrics have been active. And then within the pediatric section, I can say that we're very proud to say there's always concerns about what major organizations have been doing and how they're including UIMs in the pipeline. So what did we do? While my colleague Yasmin Tyler Hill, who is president or chair of the PED section, going out in 2023, said we ought to get all of the major pediatric organization leaders, not people in lower ranks or in special titles or anything of that nature. So this will be the third year coming up in Chicago. We've had the president of the American Academy of Pediatrics, the American Board of Pediatrics, Academic Pediatric Society, which is the honorific society, the Academic Pediatric Association, all of the levels where we have teachers, concept, which is medical student education, APPD, which is residency education, AMSPEDEC, which is the department chairs of medical schools, and the Pediatric Infectious Disease Society have come to NMA annual convention, and we've had a forum. And we've asked them, it's not the old Janet Jackson song, what have you done for me lately? But we have these discussions with them and say, what are you doing? What opportunities are out there? How can we keep the pipeline going? So just a suggestion for something that can be done realistically, to have people come to NMA, see what NMA is all about, and look at all of us as pediatricians in the face and say, this is what we are not doing, or this is what we need to do, or this is what we are doing.
We may need 2 microphones. I don't know. We have quite a few people who are. We can head over here first and then up in front. We'll go here first. I did see her hand first, and then we'll come to you next. And then, is that okay? And then.
Good afternoon. Again, Jay James, St. Louis, Missouri. So 2 suggestions for the chair of the postgraduate section. One, to engage more with the Federation of State Medical Boards, because not all physicians plan to get in trouble, but sometimes they do, from the medical student resident level. And if we as seasoned physicians are afraid of our licensing boards and are afraid of and don't know how to navigate that road and that process, we can't support, or it's difficult to support medical students, residents, and even physicians when they get in those situations. So I know that the immediate past chair, Jeff Carter, has been active with NMA for the last couple of years. I actually also sit on the Missouri board, so I kind of know that a little bit. So I think continuing to teach people how to only stumble and not fall is one thing. And then the other thing that I wanted to say is that I'm an OBGYN, take that. We take people in the prime of their reproductive life and we put them through hell and don't consider their reproductive options, choices, or the consequences of that. And so we need to start having more of those conversations. We need to start talking more about parental leave for medical students, residents, and physicians. We have some of the worst outcomes because we put people through this thing called medical training and residency at times when they're trying to grow babies, and we wonder about preterm labors, early births, preeclampsia, and all of those kinds of things. So we have got to continue to put reproductive choices in there, like help them and support them through, because this is the prime of your life. And we're saying, and they're scared of pregnancy because they don't know about leaving residency to be able to have the baby, or they have that baby and they're back on call at 2 weeks, trying to breastfeed and trying to. Y'all get it, we've all been there. I'm gonna stop.
Excellent discussion. And I just wanted to make a comment and ask a question. I sit on some boards as it relates to getting people admitted in higher education. I always tell people, especially when they talk about DEI, and they start saying we only want to come to people in positions, especially in medicine. I always ask them, I say, I'm sitting here, I didn't have the highest scores. And I said, what happened to the mission of these institutions of training people that come from backgrounds that may be less fortunate? I said, that's the whole goal. If you have a metric communication. Bottom line is you should take pride in taking someone that may not be as high in academic level based on testing scores, getting to the point where they can go out and reproductive life. And I say, so be very careful. I said, because we all have to pass the same exam. Step 1, step 2, step 3, to get out. So it's not about where you start, where you finish. But the other question I wanted to ask, with postgraduate section, when residents do get into trouble, and that trouble may not be something that they have. It could be interpersonal communication issue. It could be somebody's perception of acts of professionalism, et cetera, because all of those are metrics that they have to be scored on. Does that committee have a mechanism of supporting us? I know in the old days, there were many people that we could call upon in many medical schools to say, we have a resident that's in trouble. May not be anything they did, but they need some support. And that person can make a phone call to those programs and really kind of diffuse the issue. Sometimes it's just a matter of having someone make a phone call to make a difference for that person. Because once a person is in a residence, we certainly don't want to lose them on, things that don't have merit.
Absolutely. So the section itself being run and led by trainees themselves are not the ones who are offering the support to residents or fellows in trouble. We do certainly create a space for them to reach out to us, and then I will actually defer to Dr. Ogunyemi, who is the chair of our Educational Council for NMA, because there is a lot of work on the national level for really addressing this specific issue.
Yeah, well, thank you for that question.
Briefly, Dr. Ogunyemi.
I think, I posted in there just now. Yes. So, this is, again, we talked about the fact that maybe about 20% of our residents are in trouble. We call them learners in need. And so the question is, how do you help them? And again, you're right. Some of these issues relate to a dominant culture, which essentially is subjective. Professionalism is subjective. If you know that culture, then you understand what they mean when they do those things. And then that leads to all this issue about attribution bias and confirmation bias. They look at you one way, and then they only selectively select information that they want to use to try to put you where they are. So what we're doing again, I think one of the first steps, the primary thing we talked about is actually having learners have mentors outside their system who they can connect with. Most important thing is you're working with any learner, tell them not to self-isolate. They got to have somebody else outside the system that they can work with. That's what we're doing. So if you look at it from the GLE perspective, when you're not looking at it from a program, GLE can create a program where if the learners of the my institution, if any learner is getting any performance improvement thing, they send that learner to me as the DIO, and I develop a plan and work with that learner and I advocate with their program to ensure that their rights are actually maintained. So that's one way of doing it. But what we're trying to do here now from the NMA perspective is that we're trying to start a program called a professionalism and wellness program. Part of that is that there's any learner that's suffering or has any question, they can call us. We're going to work on a program for that, and then we're going to have some of us from the panel who can then work with that learner to try to help them be able to actually navigate that process. Again, if you want to hear more about that, we'll have a section on Sunday to discuss that at further length. So I actually invite all of you to come on Sunday so we can discuss this and actually maybe include many of you as much as possible to support these learners who are in need at this time. Thank you. Is that surely help?
That was excellent. Too often to read. It's the capacity building that we need. So please join us for that session on Sunday.
Just a quick follow-up to what one of my colleagues said. Sorry, my name is Chris Washington, I'm the chair of the CCWT. We've been doing some programming throughout this year to kind of address some of these issues and have people who are active in the conversation kind of outside of NMA. A lot of visitors aren't able to make it to NMA. And so just to what my colleagues spoke about, we are having a webinar about Black women in infertility, Black women physicians in infertility on April 21st at 8 o'clock. We did one a few months ago about Black women who are in executive leadership roles, and over 300 people log in. So please look on the NMA Facebook page because we have lots of upcoming webinars for us.
I
I know. So in order, we're going to take this young lady here, and then I know you're very patient, and then this is my group that I've seen that I've been ignoring, and then I'm going to actually ask, because we do have a lot of questions, if we can line up, we can have a line over here and a line over here, so that I can keep track of who is actually wanting to ask questions, particularly because the podium is making me unfortunately forget.
We can line up right over here, so we can be close to the front and everybody can see.
Okay, that's my question, and then bring the mic up. So Tony Noir for infectious disease. So I'll comment on the question. So comment is just phenomenal panel, and just really addressing all the multidisciplinary things that need to happen. And I love the emphasis on not just the individual, but all the systems that have to be in place. And just because you're a mentor doesn't mean you're a mentor, the coaching and all those things that need to happen. So thank you for really addressing these. And so I had a question, which was around some of the things I brought up around the fertility preservation, and just kind of at that age in the 20s, right? What else is available to help support in the non-clinical, non-academic parts? And you've talked about some of those social things. In terms of really being able to work with the students, because what we find is that some of my daughter joined SNMA 2 years ago. It's the best thing that happened to her. Just so kudos to kudos. And today, she just sent me a photo. Today is her last day of med school. And she sent me one of those first day of school. She carried it on through college and med school, and she's done. She matched last week, it's all good. But her SNMA crew is she met them on interviews, on match day, they kept in touch. And one of the things they found is that just never losing whatever their passion was for medicine. Medicine is a sprint, and it's sometimes like, but like one of the things that they found is just really staying in touch with whatever it is that brings you joy outside of medicine. And I think maybe the younger generation is doing that better than we did, and losing ourselves in medicine, dance and drama and theater and whatever it is, and side hustles and all of that. But what she's seen and she's brought is like a lot of the women, I don't want to say girls, do that more, but what's happening with the young men in terms of that kind of mentoring, and are there programs specifically that really help the young men? Because we're seeing both from med school, residency, even young faculty, that it's a lot of them are doing it alone. And I'm pretty emotional about it because I have friends who have sons and nephews are just young men who it's a lot harder, and then it becomes this self-fulfilling thing where everyone's just, so I know there's a lot more things put in place for young women. Young women try to find each other, and they've done that in groups from a young age. They figure it out, they talk through their issues, and just for the young men. So I'm glad to hear there's a wellness thing that's about to start, because it's a lot.
Yeah, I can quickly just respond to that. There's a black men and white coach. There's a black men and white coach that's actually in nearly all medical schools that supports young men. And then also the SNMA, actually many of the SNMA groups also support the black men, specifically they form their own groups as well. And then what we've actually done very specific, there's some schools that actually have black high schools. We have some high school programs that specifically only for black boys. We're doing that now. And then in many of our medical schools, at least in mine, we actually are intentionally mentoring the black medical students as well.
Thank you all. We had a similar program last year with surgery, executive medicine, and community health. And I'm glad to see this make a bigger stage in terms of a joint, something that built into the NMA program is Deidre had a resolution passed to start addressing this issue. I want to ask, for those who may be here on Sunday, is there enough to talk about on this subject that we may need to try to push for having a push for a resolution to have this as a permanent part of either Colloquium or the national meeting, so that we're constantly having these conversations as a body and not in piecemeal?
Yeah, I think that's an excellent point to raise. The answer, is there enough to talk about? Yes. The solution, I think that's a great suggestion for the solution and one that I will absolutely take to the board.
I just want to add, because this is really important in the sense that we're talking, but we need to be doing. And the doing that we need to do is that we need to be identifying all the learners and young physicians who are suffering and have a program for them. So again, we're trying to have this meeting on Sunday to discuss this. So if you can come and can be one of our champions, that would be wonderful.
I'm Dr. Donahue, anesthesia in New York. My question was sort of flipping things a little bit. We're talking a lot about the learners and having been through residency and so on and so forth. I think, how do we talk more and act more around the bias? Because a lot of the bias that our residents or our young people, or however we want to describe, a lot of these things that they're enduring or going through or dealing with are very ordinary, and they're overrepresented minority counterparts are having similar experiences, but not with the same penalty. But whether it's a gender piece or those who have belong to some other minoritized or marginalized demographic. But where is the discussion and the action around penalizing those faculty who it can be fairly evident that they are coming from a place of bias? And because I feel like it's like this whole question, we think about Ruby Bridgette's in New Orleans. She's 5, she's going to the 1st grade, and her parents are telling her, please behave this way, that way, and the other. And it is the white children and their parents who pulled all of their kids out of school. She was not the one to be bad behaved or to be more vulnerable or more likely to behave poorly. It was just the scrutiny of the system that she was under. And I feel like we talk a lot about the residents again and again, like, it's their fault or it's the burden or the stigma of being Black and having been someone who went through residency. I had a period of unstable housing. I was a single mother. I went through a lot, and I got through and got out, and I'm grateful that maybe I wasn't excessively scrutinized, because I definitely had some issues. But where and when do we talk about that part of it? Because it's a power piece as well. It's a racist, white supremacist power piece. This is since the Flexner Report. The Flexner Report not only lost us medical school, but it made it very difficult for us to build residency that Blacks didn't even attend. Initially, after residency was required, we weren't even permitted. It wasn't until after World War II that in large numbers we were even admitted into residencies. This feels essentially to me sometimes like a continuation of that continuous impulse to suppress us, but I feel like we're constantly addressing it from bottom up, where how do we figure out how to sit on these gates or penalize the ones who sit on the gates to make these judgments and cause these problems. That's
All right, I will address that very briefly. In the sense this is an ongoing issue, and even in Black institutions, of course, in Black institutions, so there's no institution that's free of this. That's the truth. So one of the things that we have to stop the silence. You have to break the silence. If you don't break the silence, we can't do it. Most institutions actually have process for dealing with this. The point is that people are free of retaliation and intimidation, and then don't follow that process. So one is, I want us to listen. We have to manage. I understand you have to work with people. We need to manage them. And what we need to do is we need to be giving our learners that power and that authority and that confidence. If you're being mistreated, tell someone. If you don't tell someone, we don't know. So really what I think is most powerful is that we need to have them start telling these stories, because the more they tell the stories, we can make the difference. But most of the time they keep quiet until it's too late. So really the best thing is that tell them once something doesn't feel good, something looks different, you're being treated differently, you need to find somebody to talk to at that time. That's the best way to start off. One of the ways we can start stopping this.
Okay, thank you all. This has been a great conversation. And so one of the things that I just wanted to mention is that I mentor a lot of actually physicians with the organization. And one of the things that I look back over is in terms of emotional intelligence. And just people having that, and then just really understanding the gaslighting and the microaggressions and the trauma that occurs around that, and how it started earlier in their career. And I think that if we have a curriculum that really helps, like medical students and residents really understand that, then it helps them to manage up and manage down in situations because, I'm currently dealing with a resident who was dismissed from our program. And one of the things that, as she's spoken to me before it happened, and because what you all are saying is true, is that it's not a matter of what's right or wrong. It's a matter of, do you want to get through with your residency, right? Because that's you can do whatever you want to do or say after you're done, but when you're in certain specialties, it's not the time to tell people how racist they are, even though they are. But that's not the time to tell them that. It's the time to find the support that you need in order to be successful in those programs. And so I think that that's a conversation that needs to continue to happen because as we've been talking over and over, is that medicine was a white man's world, right? So, so there's all these biases and racism that is baked into the whole system of medicine.
I will say, just to address that point, one of the things that the postgraduate session is hoping to do to support our fourth years as a transition to residency is to have a series over the summer that helps them think about what to look out for. Because to Dr. Ogunyemi's point, you can tell them if it feels wrong or if it doesn't sit right with you to speak up, but there are very specific things that happen so often that many of us know how to advise someone preemptively, like if someone is telling you this, this is what you should be doing. For example, to your point, right, where before, when you start getting to a point where you think your position, your residency program will be compromised, don't accept withdrawal, don't accept dismissal, but really first have this conversation with the individual before signing your name to anything, agreeing to anything. So I think there's a knowledge piece that we can work to fill that gap as well.
Thank you all. Janina McFadder, 61st National President, SNMA, student trustee. I'm actually in a board meeting, but I felt inclined to come and support this session because it is very important and crucial to our medical students and our training physicians. So I was wondering, how do you suggest about how to address the fact that not only students, as our colleague mentioned, are doing it alone, but a lot of them are suffering in silence. I feel like we've seen a lot of that within the SNMA. And how do we encourage transparency about academic and interpersonal struggles, both before it happens and before it's too late? And to know that students won't be the first and last, and transparency that there's other people who have gone through similar struggles or similar difficulties through their journeys, and how do we connect them with those people?
Dr. Downing or Ms. Hudson, would you like to add something to this question?
Well, from my standpoint, part of that is that conversation from the beginning, that we're all human, we're going through this together, you can come and talk with me, we have an open door policy. And also, even the wellness, the social aspect, connecting with someone outside of the hospital, connecting with that learner outside of the office, that builds trust as well. So just planting those seeds every time that you have that interaction as far as the faculty and the learner is concerned, that will build their trust with that faculty member. It doesn't have to be the program director, it doesn't have to be the chair of the department, but if there is that one person that they can find and they can hold on to, they see that person as a mentor, they know that that person is not perfect, if you will, but that is someone that they can look up to and they can confide in.
I just wanted to add as well that, I think, as Jean mentioned, I'm national president, so we do see that with our students, and of course, SNMA, the board and students are going through lots of different things. And I will say that SNMA and NMA is there for our members, but I don't know if enough people are aware that they can. I would say the strongest, and I would say the most valuable thing that's happened with SNMA and even NMA and a lot of these physicians is that if you guys get the call, you guys rally. I don't know if enough students, residents know that, and they don't have to know. Like you personally, if they get that call, someone's going to call someone, they're going to get enough to know, and they're going to rally because you understand the value, you understand to keep that person in that position, if that's what they want to do, right? If that's the way they want to be, is really important for their well-being, but also the well-being of our community. And that's what we're really rallying for as well. So I'm not sure how we get people to see our bat signal or how to call for that. But I think that's also important because I do think that, I know it happens for our board, I know it happens for a lot of SNMA students, whether they're on the board or not, but I think it just needs to happen when they leave, SNMA and say, hey, even if you're in residence, you can still reach back and, we will find someone for you.
You want to shake first and then I'll take you.
Hello, my name is James Ankey. I just had a couple of comments.
Do something national radiology, guys.
My first one, I will say that I can only really talk to my experience. I feel that in medical school, at least, if they're not able to kick you out in the first years from doing exams, in the third year, the professionalism aspect becomes a very serious issue. I will say, I was targeted for professionalism, and I, of course, just thought, that was just me. But even, I graduated last year, and I did a year of research, and even now, people, both last year and now, have been coming to me and asking me, like, how did you navigate this professionalism issue? And they're telling me that I can't return the clinicals today. And so, the professionalism, it's a very serious issue that needs to start at least in the third year for sure. And then my other comment was with competence-based learning. You really do need to create a PowerPoint on the competence-based learning. I have made that. Share that with me, and I'll take it back to my school and share it with everybody else. But with that, yes, even as you said, when you're a resident, you don't know anything. When you're a medical student, you don't even ask about working in a hospital. And so you also start to kind of learn, again, like I said, I'll just talk with my experience. Like, I was diagnosed with ADHD during my third year. So then I started to learn how to navigate working in the hospital with ADHD. Being a medical student, being asked questions, I started to realize, I'm really smart, but I don't like being asked questions, especially on the spot. If you tell me tomorrow, if you say tomorrow I'm going to ask you this, then I can have the best presentation that you've ever seen. But if you look at me and ask me a question, I don't know the answer at that point. And even again with the professionalism thing, knowing that you can't just say like, oh, I don't know, I'm not sure. You have to kind of, you're going through it. Like, that's again something that you don't know until you're supposed to know. And then, like you said, there's different standards for different students. And so for minority students to say, I'm not sure, to have the slightest, slight in professionalism, it really does become a major issue. Really, that is, from what I've seen, which I'm, very surprised, because the narrative is that in third year, fourth year, you kind of just go with the flow, and as long as you're not crazy, then you pass. But that's not the truth at all.
I want to respond to that because that is important. The third year is actually the most difficult year in medical training because you're going, and when I was a flagship director, I used to take all my students and do a conflict resolution and emotional intelligence workshop before they come, because you have rotations that's only 1 week. You're going to a place where you don't even know where the bathroom is. You're the lowest on the totem pole. Everybody knows more than you. You're just a fly on the wall, and you're expected to know the system of a place you're not going to be there long. So it's really a very tough year, but I think we don't prepare our students that well for it. So I do think, again, going to SNMA, because this is SNMA, I think we really need to be having some boot camps for third year. Just let them realize how complicated, complex, and difficult that is. So thank you for sharing that.
Sorry, I'm going to talk. And I will say, I sat in a student advisory board meeting where they were kind of going back and forth with if they should talk to minority medical students about things like racial aggressions and things like that. And I was appalled. I was like, I don't understand how you can know that that's a major issue
and be unsure of if you should bring it up before you say the position. But again, like I said, when I was in my third year, and then now that people under me are still calling, asking for help, I'm very shocked to see how challenging the third year actually is. Because it's supposed to be the best year when you're no longer studying and the rest of the hospital, but it's not.
Thank you.
And actually now work with the and so I think that this panel is great in terms of its background, looking at students from getting out of high school, being interested in medicine, all the way to junior faculty. And what I wanted to say is, in Kansas City, we actually developed a kind of program or a group called Mission Vision Project. We started with a thing called Critical Mass Gathering. Basically what we did is we gathered the 3 medical schools in our area. We gathered community physicians, some of them active, and had started out with just a half-a-day session where we actually introduced the medical students to our local community, talking about specialty choices. It's going on to have keynote speakers and MCAT prep, step 1 and step 2 project. But what that to me has meant over these 20 years that I did it, 30 years in university, is practice that you can come alongside folks as their medical students, as their residents, and even into the junior faculty years. If you can bring them in a safe environment, talk to them about the things we all know in this room. I mean, we all know medicine is racist, we all know it's hierarchical, we all know it's insensitive and toxic and built to make us isolate. And if you can start talking about it, you can head some of this off. But there does need to be specialized things. Residents need to know what's in their contract. They need to know what the clinical competency committee does. They need to know that if there is an issue with them being asked to resign, like you said, don't sign that. You have to talk to somebody. You have to even get legal stuff involved. So I think the people in this room have a lot of power when it comes to your knowledge. It's just a matter of coalescing it to the point where you can relate it to the people who desperately need it. And those are, in fact, medical students and their residents. So I look forward to Sunday.
Thank you.
I really appreciate that, Maya. The people in this room have a lot of power, and I really want to make sure that we've heard that clearly. The people in this room have a lot of power, so I hope that everyone is being invigorated and energized and taking some of these conversations to think about how they can apply to their institutions. We'll keep going with our questions. Military match, general surgery.
Yeah, 2 things on the topic of black men. I think the loneliness that we felt in medical school is kind of something we've grown up with. As most people can relate. I grew up in Norfolk. If you were hanging out in a group of black men at any age, at some point it's going to be taken as something. You were going to be challenged in a way and not told to disperse, or something was going to happen. So that's a mindset that we've grown up in, and I think most of us at this level feel that we had to do it individually to be allowed to get to a certain space, if that makes sense. In terms of the AAMC data, I think something that's interesting, if you actually take a look, and I think take a V3 by a year, the diversity numbers actually get worse as time goes on. What I mean is, if you take a look at 2014, when they released the report in 2014, there are certain numbers by race and gender. If you look at that data in 2015 for year 2014, there will be more Asians and more white, but less black, less Hispanic, less Native American. And as time goes on, those specific years get worse. And it does it every single year. I actually reached out to AAMC about that because the reports are supposed to be drawn October 31st. Matriculation data should not change for a year. Like whatever October 31st is in 2014 should be that forever, right? But it does. But I got no response besides that's what the schools are reporting. So we're actually a little bit less diverse as time goes on based on the data. But in addition, the DO schools is another issue, especially when you take a look at where they're matching today, right? They're matching into residents that have traditionally been MD. But DO schools last year was 3.9% black, this year was 4.5% black. But actually, when you take a look at the overall med school data, that drops from 10% down to 7% overall for black students. And then when you factor in the fact that we're kicked out of residency, or when you factor in that we're overrepresented in preventive med and representing family med, but not in the other specialties. That also factors in more. And then when you take a look at the Supreme Court and all this other stuff, you know, for the next 40, 50, 60 years, now we're behind. And so a pipeline system, a true pipeline system with an input, output, controls parameters, really needs to be developed for folks starting at age, I would say no later than 3 years old. So we have CSAs in place that can pay for college, you know, reading by 3rd grade, all of that stuff. Otherwise, we can't rely on the numbers that are given in the undergraduate medicine because it's just not simply enough.
So let me respond to you by what we've done in Charles University. Charles University just started its own LCME 4-year medical school only 2 years ago. Before that, we had an association with UCLA, and we trained 28 students every year, but it was a UCLA program. It wasn't an HBCU program. So we started it, and this is what we've done. Our class, we have 60 students. Of those 60 students, 95%, 57% of them are Black, 37% are Hispanic, and maybe 1 or 2 are something else. But what we've done, which is even more important, is that of those 60 students, about 35% of them only had admission to CEU. That is, nobody else was going to give them a chance. And then when we look at an average GPA, it's lower than everywhere else. And then what's more important is that we're really taking students who are low in socioeconomic class. So Pell Grant is the grant that you use to assess the socioeconomic status of medical school. In all schools, the Pell Grant, which means that your family makes less than $50,000, is usually about 20%. In our school, 60% of our students have their family makes less than $50,000. So we really have a class of students who nobody else will give a chance, and we're giving them a chance. And that's the point, is that if you take all the very smart black and brown kids, they can go to Harvard, they can go to Yale, they're going to get a full scholarship. But you really need to work with those ones who nobody will give a chance. So our pipeline programs, so again, I don't want to use the word pipeline, I want to say pathway programs. Our pathway programs should be focusing on those who are discarded, who are marginalized, who have never seen anybody that looks like them, who are not in the center, who are somewhere else in an urban area or something. Those are the people we should be searching for, and those are the ones we need to get to become doctors.
Yes. Alabama, which has a large family medicine, I think 2nd largest, 3rd largest in the country, family medicine residency program. I was actually in another department, community medicine, population health, but I had to really serve as an advocate, and I'm saying this, that we probably need more scorecards because invariably it's a very hostile environment, no Black faculty in family medicine. Invariably, they would always target 1 or 2 either Black or international residents to kick them out. My job was to mitigate as much as I could to at least let them finish the first year and then transfer, which I did. I would say maybe 6 or 7 have done that for various reasons. Some didn't like the city. Some had mental health. One had mental health issues, was really diagnosed as being depressed, didn't want to take the medication because she was very religious. So just so many different variables about why they would need to transfer. And then I would have to try to keep them in for the year. And then some of them would go on to do other residencies. So could you kind of talk about just the impact of that and how that would impact on them staying in a residency or transferring to a different residency? We know we see that with some surgical subspecialties, etc. And even with, we brought our first Black OBGYN in, the problem wasn't the faculty, it was the hospital. So she didn't last a year. I mean, this emotional intelligence is so important because I kept saying to her, come on, let's have lunch. But she never would meet with me until it was too late. And so really recognizing the signs. I know the signs, but the residents talk around me like I'm invisible. I don't like her. She's too hard. And then, just this is like this domino effect that happens year after year after year. So really maybe
making some of this data public so that people know these are hot spots that you might not want to come and do a residency in, and really make those institutions accountable as well. I think somebody was talking about that. But I had to advocate from the outside, most definitely, because they had no Black faculty in the department. Sometimes they would sort of work with me around that. The other thing that really helped was that our associate dean for academic affairs was Black. So it would be me and him mitigating all the time for these targeting of Black and international residents and students.
Thank you. I just want to say very quickly that we have to have there's some places where you cannot thrive, no matter how hard you try. It's just not a place that is meant for you. You did talk about fit, which is important, is our concept. So I do think we need to guide our trainees when they're looking at a place, look at the picture of that place. There's no point going to match in a program that you don't see anybody that looks like you. You need to have a critical mass if you're going to do that. And if you're going to go to one of those places, then you need to be prepared, and your emotional intelligence, your humility has to really be really sharp for you to be able to stop at those environments. So I do think we need to help them with that, looking at the profile of that institution.
I do also just want to note to that topic that I think the indefinite transition of the residency interview process to virtual, while it has certainly unburdened a large financial aspect of traveling across the country, it really does make it extremely challenging to get a fit because anybody can tell you anything.
Exactly. Yeah.
Like they can make a program seem a lot more palatable and hospitable, and then when you get there is when now the challenge becomes when you see it in real time. You did not really have the opportunity to speak to the residents, and what happens often is that the residents who come to these mixers are the ones who have all the good things to say. If they're already burned out and over it, you will never see them and you will never hear from them.
They won't get
you will never get your warning signs that the program is not where it should be. So I do think that programs having the opportunity to think about second looks after rank lists have gone in is something that has started to bud through our residency programs. So that's an opportunity to at least be able to, in the time after programs submit their rank list, before medical students submit their rank list, having an opportunity to help fund students to get to programs to see places where they're at is another thing that we can consider. We talk a lot about mentorship, but there is sponsorship as well, which is another way that many of us who are in different financial situations than the students and the residents that we mentor are in to think about how we support them that way. We have these three individuals in line. We're going to take all three of their questions and then we will transition over.
Hi, I'm Carol Guy, Regional Chair of Delaware. I'm a pulmonologist. So thank you to the panelists for this robust discussion. The bad news is I graduated in medical in 1988, did residency at Temple, and did fellowship pulmonary critical care health, and this has not changed. It not worse. Yes. So my question is, I heard you, Dr. This production name, please forgive me, Dr. Ogunyemi.
Yes, you said it.
I love this actually, Dr. City, okay. So my question to you, you alluded to the fact that there's still problems at HBCUs with students in, you use the term, our students were assisted, or rather they're struggling students. Do we have percentages at HBCUs compared to the PWIs to know what is the difference in those two groups between our struggling students?
I'm not sure your exact question, but I'll tell you something is that the HBCU schools are truly not all HBCU schools, and I'll tell you why. Because their residents have to go to various clinical sites. Yes. And those clinical sites are outside, so if you're doing family medicine, you're going to some clinic somewhere that's not part of your institution. And those places are different from what your institution looks like. So in my case, for example, in Charles University, where we have students in Long Beach, VA, was in Veteran Hospital, and many institutions like that. So my point is, these students come in expecting to work in a real, culturally appropriate, concordant environment, but half of their institutions are elsewhere. And then because they have that mindset that these are the kind of people they're going to deal with, then they're not ready for that. And so one of the things that we have to do is to let them know all the areas they are rotating to and actually try to set them up for those areas.
And I like the idea about any NMA creating a report card about some residency and fellowship program. Maybe we could do a report card to hold people accountable. That maybe something could work.
I took notes. Don't worry. I love that.
Yeah, I like that too.
Hi, I'm Ronald Ross from Great Forest in Winston-Salem. And this is not really a question, but it's actually a comment that may be an idea that can be thrown to everybody else that may be supporting medical students. I instituted the program, we at the Twin City Medical Society in Winston and Wake Forest, program called March Onward, where we have our combined estimation, where we have our students come to meet the faculty in their transition period, which is in March. That's why we call it the start of March. So it's in March where they move from one year to the next. And what has been most successful for them, and this speaks to the issue of the young gentleman back there about professionalism and those type of things, is we've had a panel of the students from the year that they're moving from to the year that they're moving to have the students ask questions of those students of how to navigate the year they just finished. And that has been found to be very helpful to give them hints and to know which ones to look out for, what to be, and especially on the transition from second year to third year when it goes to the clinics, of how professional, how to present yourself, how to be ready for questions and those type of things that he spoke to, and those type of issues. So I just made the comment just to have this as an idea of something that can be used maybe at some of your institutions in order to help support the students so that when they walk into the next year, in the matriculation process, they had Black students who had gone through the year just prior to, because sometimes the faculty are a long way away, we make comments too, but that they can get ideas and it has helped them culturally, that it has to be able to navigate a little bit better if you have their radar up about how to deal with some of those situations.
Hi, Cheryl Holder. I'm at Florida International Herbert Rothman College of Medicine in Florida. And some of the issues about Black and white in our current administration, they really are not going to acknowledge any organization that's going to be directed towards Black males or Black females. So I am looking how the SNMA could help us in the local societies bridging this. Many times it's very hard on the students to really connect with us. And I think you may be able to, I don't know how well, because we've asked before, like Region 4, where we are, to help us connect with the students and encourage the students to sort of understand how best to work with us. If there's some way we could do this with the local medical societies. Because we have 9 societies in Florida, and each of them would be willing to be able to reach out, but the schools cannot divulge any information on any of their students to the community. So it has to be the students reaching out to us. And many times the students want to know how come we can't reach them, but the schools aren't allowed to do that. And especially now in Florida, they're not going to identify anybody as Black, Hispanic, or any other way. So I'm hoping the SNMA can figure out a way to develop a system of connecting with the local societies. And the 4th year, you have all the information on which Black students go where. Again, the local communities never get it, and the medical school will not release that information. Is there a way we could get that partnership so we know who might be even coming to Miami? We don't know. When you get to the hospitals will not release that information to the local societies either. So we need an intermediary to help us connect with the people who come to our state and to reach out, even if they don't join the local, but to offer that support to them. Because they come to us late, and we're like, if we knew you were not here, we would have. But I think if the SNMA could help do that intermediary, and I love the report card, but then as an academician, it needs to be in research. I don't know if we can do anonymous surveys, and with your assistance, and develop that research and put it in the medical literature. And we have our own journal, so we don't have to worry about New England Journal accepting or not. We publish it ourselves, that report card, because there's tremendous bias with the medical students. I've been on admissions for years, and in academia, I got promoted after how many years to get professor. It took me quite as long as a Black female physician to get to my professor title because of so many barriers, and these things need to be researched and demonstrated and put in the literature.
I just want to comment first. I appreciate that the system does actually exist. There are opportunities to optimize it, is what I will say. So there is a relationship between the SNMA and the NMA where all of the graduating 4th year medical students are able to opt in to have their information released to us so that we know their updated contact information, where we can reach out to them to find where they match for residency and all of those pieces. And then when the system is optimized, what that then allows us to do is collate that information and share it with the state and local societies, and to share with them a comprehensive list of all the state and local societies where they are heading to, so that before they start day one, as they're looking for an apartment and they are finding their community before the first day of residency starts.
Again, I just wanted to add, I know there's a lot of talk about how we support students as they go into residency. It may be a little late now because we already have our conference in 3 weeks, but we have an entire track called Fourth Year and Beyond, where really that transition between, now you're matched or you're moving on to whatever your next phase is. What are some of the things, the tools that we can help equip them with to do that? And so I will say this about SNMA in terms of our conference. We start out fast with everything, and also too, folks want to, even for our sessions, and that happens probably the same time the NMA conference is going. That's when we're sending out those calls for proposal. But I would say the 4th year track, I think there's lots of opportunities there to get in some of the information, even for the postgrad section, in our relationship as we're building, to make sure that happens, the information. And I think also for them to know their rights, as you said, they may not know, don't sign anything, read, or just, take a pause. Try not to get kicked out, you may want to leave before they kick you out, or whatever the different tactics are that they need to survive, whatever this is, so they can get to the next phase if they cannot stay where they are. And I think that's what our students are missing at that stage, is how to navigate, and what are some of the options that they have, because I think sometimes they feel like they have no options.
Final words, Dr. Ogunyemi.
Yeah, Dr. Acholonu, I just want to comment on the fact that we have actually thought about some of these processes. And we're thinking about rolling out some webinars related to this topic. So these conversations and dialogue have given us some ideas about what we should be focusing on. So I think that's very important. From an action plan, I think working on a report card, which may actually be very complicated, but it's possible we can start somewhere, because either we do it with the medical students going get the medical students to do their first year of residency will be a way to do that, or we have to find some other ways of getting information from all the programs. So that's one thing we can hold on, that we can try to do. The other one, I think, is the major one, just listening to the conversation, is about doing some boot camp for 3rd year medical students. I think that's also another very major thing we can work on. And I think this coaching, finding a way to coach and support the students and make sure they're not isolated, just making sure they have a group, I think it's also another major important thing we can work on. Thank you.
I want to thank you all for bearing with us and hanging out until the end. Initially, the plan was for us to have a breakout conversation to discuss some solutions, but it really organically came out in the discussion anyway. And so I think we've had a lot of really tremendous ideas that have been spoken in this room, things I've taken note of to bring back to the board for the NMA, things that each of us can bring back to our respective institutions to do to continue to support everyone at the different levels, K-12, our pre-medical students, our residents, our fellows, and our junior physicians. I will allow my esteemed panelists here to share one final word that they might have for the group as we go, and then we will end our session.
I was laughing. Dr. Ogunyemi said
He wants to have a final word. He wants to bring it home.
Well, I'm going to say something which is not going to be popular, and I feel a little bit bad about it. This is actually my first time coming to NMA, so I appreciate you all inviting me here. It's been a very invigorating conversation. I'm so honored to be in the room. I'm happy to be in the room. I've seen one of my colleagues from Howard University College of Medicine. And so I will definitely be back. I appreciate it.
So I think for me, the question is that we've talked a lot about the pathway and maybe the challenges, but we're in, I would say, a fight right now. And I was on a panel yesterday talking about we really need Marines right now, right? We need folks that are going to move forward into whatever this next phase is, which is very difficult. Lots of DEI programs and offices are changing and closing down, and that means that support for our medical students will be dwindling. And the biggest support that a lot of these medical schools or Office of DEI did was help them to, some of them gave them support to join SNMA, to attend our conference, to even, exhibit at our conference. So there will be a period right now that we're in that is very critical of how we think we can support the ones that are here now, right? We're always, I think that's the thing, it's a battle on all fronts. And the reason why I said that is because we also have to look at different partners that we need to engage with. Like, are we looking at what's happening in education, and maybe especially the pipeline piece that we talked about. We need to be working with those NEA groups in the schools if we're just thinking about what we need to do about our pipeline piece. And then, of course, as I said, we just have to really think about how we move forward. I think our mission is strong. What we're doing works, and I think that we're not going anywhere. But we do have to recognize that COVID did a number. You have this decision that's doing something, but I would say that last year it did seem like it had a huge impact on the number of pre-med that attended our conference, and this year we've had the largest number of pre-med registered to come to SNMA conference. Last year we were under 500, this year we're almost at 700. So what I'm saying is that this is also really difficult. People are still marching forward, and we just have to meet them and get them over the battle line. And I think that's where we need to be as we think about the future as well.
Yeah, I want to talk about something else that came up in the conversation.
Every time you step forward in your seat, I get nervous.
So, actually, I want to talk about resilience and the learner themselves, taking care of themselves, being able to navigate the system. We can try to help them all we can, but they have to want to help themselves, and they have to be able to survive and thrive on a day-to-day basis. So I think one of our colleagues here mentioned emotional intelligence, which I think is important. And I really think we need to be mentioning that and discussing that with the learners. Do you have self-insight? Do you know how you react to things? And when you react to things, do you know how to manage yourself? Can you manage yourself in the moment? And then also, do you have social awareness? Do you know how to read the room, your faculty, your patients sometimes? Do you know how to actually interact with the patient to really be able to read what the patient really feels? And also then, do you know how to do relationship management? So I do think we need to teach them about emotional intelligence. We also need to teach them about resilience development. All of us have cognitive distortions. We have automatic negative thoughts. We have some troubling mindset, maladaptive perfectionism. There's so many steps that we have. And my point is, also you need to be aware of when you have these automatic negative thoughts about putting yourself down like imposter syndrome, how do you help yourself when that happens? What kind of framing can you do? And then do you have self-compassion? Many of us ourselves are our worst enemies. We criticize ourselves when we do something, really push ourselves down. But we need to have some level of self-compassion to actually be able to be kind to ourselves and be able to have a mindfulness and be able to rephrase a negative situation into a positive outcome. So again, I do feel that one thing I really want to focus on is that we need to develop some kind of resilience training to support all the learners and support ourselves as well. And I'll stop there. Thank you all.
Thank you. I want to thank our panelists again for joining us. I want to thank all of you for your insight, your thoughts, your engagement and readiness to really put boots on the ground and think about how we address this important topic. I thank you all for the time, and just one more round of applause for our panelists. I think that's the end of our programming for this evening. So again, thank you all for coming. And the panelists will be here for a little while afterwards in case you have any one-on-one questions.